All right, good evening, everyone. Today we'll just do our lectures on opioid side effects and their management. Opioid side effects and their management. All right, we'll follow this outline, introduction. We'll talk a little about opioid receptors, their mechanism of action, side effect of opioids, and management of opioid side effects. And we'll discuss some likely exam questions as usual. All right, by way of introduction, we are familiar with opioids as an institute. They are the gold standard for pain relief in acute pain management, especially post-operative pain. And these are substances that are derived from the poppy plant known as the Papaver somniferum. All right, opioids are different from opioids slightly because opioids are naturally occurring substances, all right, but they are derived from the same plant. On the other hand, opioids can be synthetic or semi-synthetic. So a bit of differentiation is that all opiates are opioids, but not all opioids are opiates. I hope we get that. Okay. Now about opioid receptors, traditionally there were 3, but there are 2 more have been discovered. So we're going to look at 5 of the receptors for opioids. We have the mu receptors, the kappa, beta, nociception receptor, and zeta receptors. And each of these receptors observe some particular effects of opioids in general. In addition, all these different types of opioid receptors have subtypes. For instance, the mu receptors have mu 1, 2, and 3. While kappa have 1, 2, 3 also. So this subset also further observes some fine details of opioid effects. Okay, we'll look at this on the other side. So the mu receptors 1, 2, 3, what they do is they bind to endogenous ligands like the beta endorphins and endomorphin 1 and 2. And the precursor is the pro-opioid melanocortin. And the mu receptor 1 is responsible primarily for analgesia and the dependence effect of opioids. The mu2 receptor observes euphoria, dependence. It accounts for the respiratory depressive effects of opioids. They pinpoint pupils, decrease digestive tract motility, and constipation. On the other hand, the mu3 receptor causes vasodilatation. So you can see that even within the receptor types, we have subtypes that are responsible for specific effects or activities of opioids generally. The kappa opioids bind to dynorphin A and B, and they provide analgesia, diuresis, and dysphoria. The delta receptors bind to enkephalins, and they play a role in analgesia and reduction in gastric motility. The nociceptin receptors cause analgesia and hyperanalgesia. This depends on the concentration. The higher the concentration, all right, of the higher the receptors bound, all right, the more we have hyperalgesia. The zeta receptors regulate developmental events, all right, in a variety of normal and tumorigenic tissues and cells. Really, they do not have much analgesic effect like the other ones. Now, this table was coined from one of my references. You can see that the mu receptors used to be known as OP3, all right? They have non-selective effects on beta endorphins and enkephalins, why they are specific for endorphin 1 and 2. The beta opioid receptors, formerly known as OP1, All right, they are not selective on both enkephalins and endorphins ligands. The kappa receptors used to be known as OP2, and these are attached to the dynorphin A and dynorphin B. All right, and the nociceptive opioid receptors, known as OP4, like we said before, all right, cause the release of nociceptin and orphanin FQ. The reason why it's important for us to have an understanding of the different opioid receptors is that you may be able to predict, all right, which receptors will cause which effect and which subtypes of the receptors will be responsible for the different effects. So broadly speaking, opioids are classified, all right, based on their source, based on the structure, and based on their effect, their function. So based on source, we have naturally occurring opioids, just like, for example, morphine and codeine. The semi-synthetic includes tramadol, heroin, and oxycodone. Synthetic includes fentanyl and pethidine. Classification on the basis of structures. All right, we have different ones. We have the phenanthrines, the benzomorphins, the diphenpropylamines, and all that, as you can see on the screen. And different opioids have these structures which are kind of similar, but which also indeed represent the different types of effects that these opioids have on the body. Their functions, classification based on function, we have pure agonist, the morphine and the codeine. We have partial agonist, we have mixed agonist. All right, mixed that they have both agonist and antagonist effect, like pentazocine. And the antagonist, the naloxone. And from our understanding of pharmacology, it means that morphine, when it attached to its receptors, will give us the desired effect, the effect it produces. While the antagonist will antagonize the effect of the drugs. So another classification of opioids is based on whether they're endogenous or exogenous. All right, whether they're in the body. So endogenous opioids include what we have mentioned earlier, the enkephalins, endorphins, endomorphins, dynorphins, nociception, and orphanin. Exogenous opioids are those that are introduced into the body, but suffice to know that these exogenous opioids also bind to the endogenous opioid ligands, like we mentioned before. So broadly, they could be endogenous or exogenous, but they bind to the same receptors and activate the same chemicals that produce their effect. How do opioids work? There are different mechanisms of actions of opioids. All right, generally opioids act, all right, both presynaptically and postsynaptically, all right, through the activation of G protein coupled receptors. And the effect is to cause inhibition of adenocyclase and therefore the activation of phospholipase C. The presynaptically, opioids block calcium channels, all right, and this causes inhibition of the release of neurotransmitters such as substance P and glutamate, which contribute to pain sensation. All right, postsynaptically, on the other hand, they cause opening of potassium channels, which lead to hyperpolarization of cell membranes, which make it very difficult for action potential to generate nociceptive transmission. All right, the first three receptors we used to know, mu, kappa, and delta opioid receptors, they can cause analgesia both at spinal and supraspinal level. And this is just through the activation of G protein coupled receptor activation. The second mechanism of action is through the inhibition of serotonin reuptake. And this is important. This mechanism of action is important because by this action, they cause an increased release of intrasynaptic serotonin. All right. And this is important, especially when you are giving your patient multiple drugs. Agents that have serotonergic activity, when combined with opioids, can have what we call serotonin syndrome. So opioids that have this mechanism of action include, tramadol, oxycodone, fentanyl, methadone, dextromethorphan, meperidine, that's your petidine, codeine, and all. So when you are prescribing this class of opioids, you should bear in mind that they may precipitate serotonin syndrome in patients who are taking agents with serotonic activities. The third mechanism of action of opioids is the N-methyl D-aspartate receptor activation. And the commonest opioid that activates this receptor is methadone. And what it does is that it agonizes the effect of glutamate. And this is the reason why methadone has found use in the treatment of neuropathic pain more than the other opioids through the activation of NMDA receptor. So how do you administer opioids? All right, there are different routes of administration of opioids, and this depends on the type of opioid that you're using and the severity of pain. The route of administration is important because it influences the onset of your peak analgesia and even the occurrence of side effects. So you can have oral administration, parenteral, transdermal, rectal, and opioids can actually also be administered through the epidural route. But suffice to note here that for oral route, up to 50% of opioids administered will undergo first pass effect in the liver and intestinal wall, reducing their bioavailability. Parenteral and subcutaneous administration has about 100% bioavailability, but the peak plasma concentration following an intramuscular or subcutaneous administration depends on the site of administration, how bulky the muscle is, and the body temperature. All right, so you need to bear that in mind. We have transdermal pouch or transmucosal administration of opioids. And this is common with fentanyl because of its high lipid solubility and its low molecular weight. So absorption can take place faster through transdermal routes. All right, that's why we have fentanyl transdermal patch, or through mucosa, we have what we call fentanyl lollipop that can be very useful in some certain group of patients. Opioids can be administered rectally. All right, we have rectal formulations of morphine and hydromorphone. All right, these are reserved for patients who may not be able to tolerate orally. Morphine and any other opioids, actually for that matter, can be given or has been given through the epidural route for the management of acute pain and all sorts of implantable spinal bombs for the management of chronic pain and palliative care. All right, so opioids can be given through these different routes of administration. All right, pharmacokinetics of opioids after administration. There's what we call distribution and tissue binding of opioids. And this is dependent on the non-ionized fraction, the degree of protein binding, and their lipid solubility. We just mentioned that fentanyl has a high lipid solubility, and that's why it can be given transdermally and transmucosally. All right, morphine on its own has a very slow onset, but prolonged duration of action. And this is due to its low lipid solubility. All right, and this low solubility causes a delay in crossing the blood-brain barrier, and that's why it has slow onset in producing supraspinal effect. Morphine and amphetamine, on the other hand, have high lipid solubility, and that makes the absorption and distribution rapid. But the issue there is that it also results in short duration of action. All right, although if you compare fentanyl and fentanyl, although fentanyl is more lipid soluble, but fentanyl is known to have a faster onset of action and a shorter duration of action. And it's before that the reason for this is the high unionized fractional physiological pH and a small volume of distribution. That's what fentanyl. The clinical effect of opioid is terminated by redistribution of the drug from the reception site and is unbinding from opioid receptors. All right. Uptake by different organ systems like the muscles, visceral organs also contribute to redistribution. So basically, they are terminated by redistribution of the organ of the drug and is unbinding from opioid receptors. And sometimes you have metabolism of these opioids that leads to some have active metabolites like morphine that we'll see in the course of the lecture. Biotransformation. We're still on pharmacokinetics of opioids. All opioids, with the exception of remifentanil, are metabolized in the liver through the cytochrome P system. All right, the clearance rate of these metabolites is dependent on the blood flow of the liver due to the high extraction rate. For instance, morphine is conjugated with glucuronide to form M3G and M6G, and these two are potent metabolites. Petidine or meperidine is N-demethylated to normeperidine, which is an active metabolite that has some seizure activity. Codeine is a prodrug that is metabolized into the active ingredient, morphine, in the liver. All right, tramadol and hydrocodone are opioids that are metabolized by O-desmethyl, tramadol and hydromorphone respectively. All right, and these are the active forms of the agent. So before tramadol and hydrocodone could act, they need to be metabolized into the O-desmethyl, tramadol, and hydromorphone. Remifentanil is an opioid which has an ester structure. Don't forget that we said opioids can be classified based on their structures. All right, because remifentanil has an ester structure, it's susceptible to hydrolysis by non-specific esterases in red blood cells and tissue. Note this, because this is the only opioid that is metabolized through this system, okay? And this is why it has a very short duration of action, and it also has, lack of contact sensitivity, and it does not accumulate with an infusion device because of this ester hydrolysis in red blood cell tissues, red blood cells and some other tissues. How do you eliminate these opioids? They need to be eliminated from the body once they've done their job. All right, opioids predominantly undergo liver metabolism, all right, with renal excretion of its hydrophilic metabolites, all right. The major determinants of the elimination is the hepatic blood flow, all right. 5 to 10% of morphine is excreted unchanged by the kidney, all right, and it has a risk of accumulation, which obviously will lead to resultant prolonged duration of action. For instance, if you have patients who are on acute renal failure and all that, so you need to be careful with morphine because the risk of accumulation will lead to prolonged duration of action, and it actually may lead to respiratory depression. And that's why in ICU, I do not favor morphine infusion, like some of our colleagues do. I do not favor morphine for continuous infusion. It's good for acute pain, maybe boluses, but for a continuous infusion, especially for a period long of day, and in patients whose renal status may be in doubt, you can have prolonged duration of action and difficulty with winning your patients off the ventilator at the end of the day. Meperidine metabolite, that's petidine, may accumulate in renal failure, and which increases. Don't forget that its metabolite has seizure activity. So in the presence of renal failure, all right, you can have the metabolites of meperidine or petidine causing some seizure-like activities in your patient. Sulfatinib metabolite is excreted in the urine by, these are possible single best answer questions. When you come across them, remember that you've been taught. All right, the pharmacodynamics, this is what the drugs, opioids, do to the body. Pharmacokinetics is what the body does to the opioids. All right, so I put this table here to just briefly tell us the different effects on different systems in the body. All right, in cardiovascular system, opioids usually can cause sinus bradycardia, all right, except petidine, which can have tachycardic effect. There's a slight decrease in mean arterial pressure, all right, and greater reduction is seen in opioids that have histamine release property. It's been said that without histamine release, most opioids have minimal or no effect on systemic vascular resistance. Myocardium, there's no effect on contractility, all right, except petidine, which is a depressant. And there's reduced myocardial contractility in terms of ability. All right, so these are the cardiovascular effects of opioids generally. On the respiratory system, most opioids will cause a reduction in respiratory rate and tidal volume, and obviously minute ventilation, because minute ventilation is actually tidal volume times respiratory rate. All right, it can increase apnea threshold and reduce sensitivity to carbon dioxide. And don't forget that carbon dioxide is the what's it called? It is what triggers the respiratory system, the respiratory center rather. So if opioids reduce sensitivity of the respiratory center to carbon dioxide, you can have what we call known as hyperventilation, which may lead to apneic episodes. Opioids reduces airway reflexes and can also reduce mucociliary function. So you could have accumulations of secretions and which may be colonized by antibacterial. But the good thing about it is that they have antitussive effect, and that's why some medications, cough medications, have codeine and some form of opioids because of their antitussive effect. In the GIT, all right, most opioids cause reduced peristalsis and secretion. So it leads to reduced gastric motility, and that's why you can have bloated stomach, stomach and abdomen, and it also causes increased stone, which may lead to production of dry stool and constipation. In the biliary tree, opioids can cause increased bile duct pressure and contraction of the sphincter of Oddi. And the popular, one of the most common side effects of opioids is nausea and vomiting, and which is due to the activation of the chemoreceptor trigger zone. The enterourinary system, kidneys, opioids are antidiuretic, and they cause a reduced renal blood flow and glomerular filtration rate. In the bladder, it causes increased stone in bladder and urethra, which may lead to urinary retention. And this is important, especially post-op after you've given your patients opioids. Obviously, apart from urine monitoring, any patient you are giving repeated opioids to should have urethral catheter because of urinary retention that may arise from increased stone of bladder and urethra. Immunity, most opioids cause reduced immunoglobulin production, which makes your patients susceptible to some infections. Musculoskeletal system, there's reduced physical performance and spinal cord reflexes. There may even be rigidity of muscles. A lot of times we see this with high dose of fentanyl, as high as 10 micrograms per kg, sometimes which are useful in cardiac surgery. You may have thoracoabdominal and upper limb muscle rigidity, and you need to be aware of that and you look out for it. There's reduction in cerebral oxygen consumption, cerebral blood flow, cerebral blood volume, and intracranial pressure. And obviously, the common side effects of opioids, the euphoria, dysphoria, are effects on the central nervous system. All right, all opioids cause meiosis except meperidine, true or false? All right, you see it here. True, the impact of Endiga-Westphal nucleus, most opioids will cause pinpoint pupils. Thermoregulation, the effects on peripheral effects and response. Most opioids promote hypothermia by reducing basal metabolic rate and venodilatation with reduced thermoregulatory response. And that's one of the reasons why shivering is a common side effect of opioids, because of the effect on the thermoregulatory system. Okay, so approach to opioid dosing. I don't know if you remember, there was a time I was asking a question about opioid naivety. All right, and we'll talk a little more about it here now. What do we mean by if we say a patient is opioid naive? All right, it means that patients who are opioid naive are those who have not received opioids, any form of opioid, in the 30 days prior to any acute event or surgery. So for any patient who has not received opioids in the last 30 days can be classified as opioid naive. All right. And in opioid naive patient, you should only prescribe opioids when necessary. And it should start with the lowest effective dose and for the shortest duration as required. Let me repeat it. For opioid naive individuals, only prescribe opioids when absolutely necessary. And you must start with the lowest effective dose. And you must do it for a short period of short period. All right, the reason is because a greater amount of initial opioid exposure will be associated with greater risk of long-term use, misuse, and overdose. So for opioid naive patients, great caution needs to be exercised in prescribing opioids. If pain relief can be achieved by any other means, or any other multimodal approach is better. But if opioid is indicated, which is a good standard anyway, you must start with the lowest effective dose. And I don't know how many of us, let me ask you, how many of us do drug history when we're doing our preoperative assessment for our patient? How many of us ask, do you use drugs? Do you use opioids? Or do we check out the charts, the drug charts, if this patient has been given opioids in the last 30 days? If not, that patient is classified as being opioid naive. On the other hand, we have what we call the opioid tolerant groups. And these are patients who have received at least 1 week. All right, at least for the last 1 week, I've received morphine at 60 milligrams per day or transdermal fentanyl at 25 micrograms per hour, or any other form of opioids at all. All right. So the reason why this is important is that for patients who are opioid tolerant, they are less susceptible to the effects of opioids, whether the therapeutic or the adverse effects. All right. And this may also, opioid tolerance may also develop in patients who are on long-term use of opioids. All right. So patients who are given opioids for management of their cancer pain or chronic non-cancer pain, or who have opioid addiction, at the end of the day may become opioid tolerant. All right. So you may need to give higher doses, all right, to achieve your therapeutic level, all right? And they are not as easily prone to side effects of opioids like their counterpart who are opioid naive. All right, so this is a schematic diagram of what I'm talking about since, okay? Opioid naive, the dictum is start slow, go slow. Okay, opioid naive individual, start low and go slow. Okay, for those who are intermittent pain, it's better you use PRN doses. For those who are chronic or persistent pain, you need to be careful so that you don't have overdose of your opioids, even at normal doses. For opioid tolerant groups, you know, they are stable, they tolerate whatever I give them. So the important thing is that you need to know the effective dose they are on and start the patient on current regimen. So if the patient has been on 100 milligram tramadol before now, I think it's better for those opioid tolerant groups to start that. There's no need of going lower, all right, because it won't work. So you start on the regimen that the patient has been on, okay? And if it's stable but not tolerating, that's what we call opioid rotation, all right? You change the opioid you are using to another opioid. It's known as opioid rotation. And we'll talk more about it as we go on. For opioid tolerant patients who are unstable, but they tolerate, all right, you need to keep the correct opioid dose, all right, but you may also need to increase it, all right, by 25 to 100%, depending on pain severity. All right, for patients who are unstable and they are not tolerating, it's been advised to consider what we call opioid rotation. I hope you're following. Are you hearing me?
Yes, Prof.
Yes, Prof. We are following.
Yes.
Okay. All right. So what are the contraindications to opioid use? Many risk factors for opioid tolerance or dependence exist. But before you give your patients opioid, you want to rule out some of these risk factors that may lead to misuse. You don't want to give any patient, start any patient on opioids who have a great risk for opioid misuse or abuse, as the case may be. So there are many, I just selected some of this, okay? Patients with family or personal history of substance abuse. That's not the kind of patient you want to start on opioids. Be wary of those young, agile men and women, young age, all right? People who have history of legal problems, all right? Patients with who have frequent contacts, all right, with high risk individuals or environments, people with previous problems, employers, family, friends, all right? History of risk-taking and truth-seeking behavior. I just want to just do something new. I just want to feel high, all right? Those are not the patients for your opioid therapy. Patients who smoke cigarettes regularly and or use other substances that may lead to dependence, you want to be wary of giving them opioid. History of major depression and anxiety because of euphoria, they will keep craving for it to feel better. Patient of multiple psychosocial stratus, history of childhood abuse, previous drug and alcohol rehabilitation programs. All right, these are patients that you want to be wary of starting an opioid. Sometimes you may see in some patients, they even exhibit features of opioid-specific toxicities. All right, in this kind of patient, you don't want to start them on opioid. Yeah, you know, I like mnemonics by now. So side effects of opioids, I just coined it morphine. All right. So when you ask side effects of opioids, just write morphine and follow the mnemonics. M stands for meiosis, pinpoint purpose. And I'm sure we see that regularly. In fact, one of the ways you can know people who are opioid dependent You look at your pupils and they're dilated even though they are awake. I mean, pinpoint, not dilated. They have pinpoint pupils. Constipation, from what we said before, respiratory depression, P is pruritus and physical dependence, H is histamine release, I is increased intragastric pressure, N neurological sequelae like sedation and delirium, and E, you can have emesis or euphoria. So side effects of opioids are morphine, okay? Do we get it? Yes. Now, so we've talked about it. How do you manage some of these side effects of opioid? Let's start with constipation. All right. It's one of the most common adverse effects following chronic opioid use. There are two ways of managing constipation due to chronic opioid use. You have the non-drug and the drug therapy. All right. What you do for patients who are constipated from opioid use, you want to increase fluid and dietary fiber intake. All right. You want to increase their physical activity and give them a toilet routine. When you wake up, some of us, when we wake up in the morning, we go to the bathroom. It must happen every day. And sometimes, you know, especially when we are toilet training our children, we just tell them every 4 hours. So for patients like this, you have to give them an established toilet routine. All right, increase fluid, increase activity, increase dietary fiber intake. For drug therapy for these patients, the use of saline with or without H2 softener is important, okay? If this is not adequate, you may want to use osmotic agent like sorbitol. Note that bulk formula laxatives are also an option, although they may require adequate fluid intake, all right, and may not be appropriate in all patient populations, all right, but periodic use of saline laxatives and administration of suppositories or enemas may be needed for this patient. Know that transdermal fentanyl, Duragesic, is an option for patients who have difficulty with the constipating effects of oral opioids. All right. Transdermal fentanyl has been shown to have fewer such effects compared with various oral opioids. So for instance, if a patient told you that the last time I was in the hospital, I was given something and I couldn't pass through for a long time, these are not the kind of patient you want to start common opioids for. So transdermal fentanyl, all right, we give you analgesia, but we have reduced constipating effects of opioids. Now, the second complication of side effect of opioid is nausea and vomiting. All right, I'm sure that if you're asked, that's the first thing you'll mention. All right, nausea is, has been reported in about 1/4 of all patients who are treated with opioids. So it's quite frequent. All right, management can vary from one drug to another. All right, antipsychotics such as haloperidol are considered first-line options. All right, first-line management, for the first-line management of nausea due to opioid usage. Haloperidol at 0.5 to 2 milligram orally 2 to 4 times per day. Watch out of side effects such as akathisia, dystonic reactions, sedation to static hypotension. All right. Metoclopramide can be used in the management of opioid-induced nausea, all right, at a dose of 5 to 10 milligram orally or IV 4 times per day. And how does this work? It blocks dopamine receptors in the chemoreceptor trigger zone. And this helps to promote peristalsis through enhanced release of acetylcholine, all right? But it's not commonly used due to its extrapyramidal effects, all right, and sedation. But don't forget that in as much as metoclopramide is useful in nausea-induced opioid, it's not a first-line antiemetic to be used in the general population. In fact, some studies have shown that metoclopramide use is not better than a placebo in the prophylaxis against postoperative nausea and vomiting. Serotonin antagonists, don't forget that we have one of the mechanisms of action is inhibition of serotonin uptake. But serotonin antagonists such as ondansetron, all right, has been found to be an alternative, all right, in the management of opioid-induced nausea, all right. So you can give ondansetron Sofran about 4 milligrams or orally or intravenously 2 to 4 times per day. Antihistamine popular promethazine, all right, 12.5 to 25 milligrams orally, or you can even give it rectally, has been found to reduce opioid-induced vestibular sensitivity. And don't forget that sometimes this nausea may result from activation of the vestibular apparatus in the middle ear. Patients who experience nausea related to ambulation are most likely to benefit from antihistamine therapy. All right, but don't forget that these medications may lead to sedation and it may cause some orthostatic changes. The role of corticosteroids in the management of opioid-induced fentanyl has been the subject of debate. All right, but a lot of times I have combined corticosteroids with other non-antiemetics, and the outcome is beautiful. And the reason why corticosteroids have been used is the stabilization of nerve cell membrane, especially those around the chemoreceptor trigger zone. All right, don't forget that jitness, confusion, increased appetite, blowing up may be one of the side effects that you want to consider for patients who are on long-term steroid therapy. Are you still here or you have slept on me? One person has left, okay.
We are still here, bro.
Thanks. Pruritus is another common side effect of opioids. And it's been said that the likelihood of a patient you starting on opioids developing pruritus is about 2 to 10%. All right. And this chance of developing pruritus increases when you go through the epidural route or intraspinal injections of your opioid. All right, most of the time, this pruritus is related to histamine release in the periphery, or it may be a centrally mediated process. All right, but it's been noted that it's more of an adverse effect rather than an allergic reaction. And the common agents that are used for this are the antihistamines, the diphenhydramine, the Piriton group, all right, are used to manage this patient. Another way to take care of this side effect is to do one opioid reduction in dose, and you can actually do non-drug treatments such as cold compressions and moisturizers, especially for patients who have serious non-responsive pruritus. Some selected antihistamines that can be used for the management of opioid-induced pruritus or itching includes cetirizine, diphenhydramine, Benadryl, and all that, as you can see. Loratadine, 10 milligrams once per day, has also been found useful in the management of pruritus caused by opioid usage. We have some side effects which are centrally mediated. The sedation, all right, is common, and then most of these other ones at the rate of 20 to 60% of all your population that who are on opioid. All right, most of the time sedation occurs with the start of the medication. All right, and dextroamphetamine, all right, orally twice a day may be used, and methylphenidate may also be used in managing sedation due to opioids. The brother or the sister of sedation, delirium, all right, a lot of times persistent confusion often follows, all right, opioid use, and this is made worse by increased age, all right, infection, patient not properly hydrated, and patients with metabolic activities or abnormalities, all right. Now, this delirium occurs, and it can be treated with antipsychotics like haloperidol and what have you. And one of the things, interesting thing is the risperidone, which can be given at 0.25 to 1 milligram orally twice per day. Okay. Respiratory depression, I'm sure this is where you're waiting for. All right. Know that patients who have altered mental status, depressed respiration, and pinpoint pupils, you should immediately suspect an acute opioid-related overdose. Patient present with reduction in level of consciousness, depressed respiration, okay? And you look at the pupils, they are very pinpoint. You need to first of all put acute opioid-related overdose at the back of your mind, in fact, in front of your mind. Treatment is with naloxone, which is essentially acting pure opioid antagonist, and it has a high affinity for mild opioid receptors, and it quickly counteracts opioid action. I'm sure many times, many of us have used naloxone in trying to reverse the respiratory depression effect of opioids. Know that in normal doses, in the absence of opioid agonists, naloxone has no pharmacological activity. So it only works in the presence of opioid agonists. Naloxone can be given in small repeated doses, and you watch the effect. So it should be titrated to effect. All right. And the dose of naloxone, you put 0.4 milligram in 10 saline, and you give it over 20 minutes at 0.5 minutes over 20 minutes. Okay. All right, there are some strategies, not management now. You want to try to minimize the side effect of opioids before they actually develop. So there are some strategies that can be used to minimize the occurrence of side effects of opioids. And one of them is that dose reduction. You need to, immediately after pain is well controlled, you want to reduce the dose of your opioids, all right, while maintaining adequate pain control. For instance, if you started morphine on maybe, let's say, 5 milligrams, all right, and pain has been controlled, you want to calm down, or even whatever it is that you're given. And remember to start slow and go slow, okay? Then you may want to, one of the ways to reduce dose is by the addition of non-opioid analgesics or the use of adjuvants such as TCAs. Treatment directed towards the source of pain are all options, all right, in trying to reduce your dose of opioids, thereby trying to minimize the unwanted side effects that come with it. Another way to minimize opioid side effects is what we call opioid rotation or opioid switching. This is a concept in which one opioid is exchanged for another to improve pain control or manage certain adverse effects. Maybe you started with morphine, you want to see if you can change to meperidine. You know, you're just juggling around, all right, in order to improve pain control or to reduce or manage certain side effects we're talking about, all right? Remember that once an alternative opioid is chosen, you should give the equal analgesic dose, all right? You don't want to underdose or overdose this patient because you are doing opioid rotation. So you must calculate the equivalent analgesic dose of the opioids you are bringing on board. Patient response to opioid therapies can be highly variable. So we should be knowledgeable about the different opioids that can be interchanged. And we need to also understand the fundamentals of proper equianalgesic conversion. For instance, what it means is that what is the equianalgesic dose of let me say, 2 microgram per kg per hour of fentanyl, what is the equi-analgesic dose if you're going to use amphetamine or sulfentanyl, or you want to use tramadol? So you must understand the concept of equi-analgesic conversion when you are doing opioid rotation or opioid switching. Another way to minimize the side effect of opioids is to change the route of administration. All right, instead of doing IV, you may want to do transdermal. Like I said here, transdermal administration of fentanyl is considered or should be considered when patients have difficulty with swallowing or difficulty absorbing oral opioids. Sometimes a switch to transdermal fentanyl may be all you need for patients who have renal problems. Liquid opioid preparations are available, especially the morphine, and should be considered in patients who have difficulty swallowing pills. All right, in palliative hospice care center, rectal administration of morphine should also be considered. All right, and these are, geared towards minimizing the risk of opioid adverse effects such as nausea and vomiting. All right. The last but not the least is symptomatic management. Now, a patient has developed the adverse effect. How do you go about it? So you treat the opioid-induced side effects with medications that target that specific symptom. Okay. For instance, the patient has pruritus. You want to give medications that treat pruritus, not that you want to treat pruritus and treat other things in addition. All right. Concomitant treatment with another medication may act as a bridge to ameliorate the bothersome side effect of opioids. So once tolerance to side effect develops, the medication used to treat the side effect is discontinued. All right. It is important to remember that tolerance to constipation does not develop. All right. Therefore, long-term treatment is required to reduce the occurrence of this side effect and its associated complications, such as obstipation and fecal impulsion. Okay. You know what obstipation means? I said it here. This occurs when severe constipation makes defecation impossible. All right. You say a patient is constipated, but he can still pass some stool. But if the patient is obstipated, all right, and it can be used in English language. There are some people who are obstipated at pulling you down by all means. They are obsessed with it. All right. God will don't give them power to do so. Amen. All right, ladies and gentlemen, let's see who is on our call today. Let's see the first person. Nala, you're the first person here. Look at this question. Read the question and let's quickly discuss it in the next few minutes. Read the question, try to attempt it, and let's discuss it.
Okay. A 25-year-old chronic alcoholic with 20+ years smoking history scheduled for X-lab secondary to a gunshot injury to the abdomen. Part of the multimodal perioperative analgesic plan is the use of parenteral opioids. Answer the following questions. Joseph, enumerate the strategies to minimize opiate side effects in this patient.
Distribute it. Let's distribute it. Who are you giving B?
Joseph.
Joseph is A. Who are you giving B? Hello?
Second is Naomi on my list.